respected chairperson, senior colleagues and friends. Treating obesity to reduce cardiovascular outcome. Treating dyslipidemia, hypertension and diabetes to reduce cardiovascular risk is the standard evidence-based practice as we all practice. But the concept of treating obesity just to reduce the risk of cardiovascular complication is not popular. That's because there is no clear evidence to recommend pharmacological intervention. As the chairperson already mentioned, many of these drugs initially, even though they brought down weight, cardiovascular outcomes were poor. Now we have one revolutionary breakthrough drug, that is GLP-1 receptor antagonist. It was originally developed to treat diabetes, but it caused a paradigm shift in the management of obesity. That's because it's the first drug to show cardiovascular benefits by treating obesity. And now you can see many of the magazines, including Time, writing cover stories on these weight loss drugs and surprising benefits of weight loss drugs. Let's go on to elaborate on these things. Thanks to these guidance by FDA in 2008, any diabetic drug before introduction, they have to prove the cardiovascular safety. This was done in 2008. After that, we have many cardiovascular outcome trials, and we got one good class of agents as SGLT2 inhibitors. Now we have GLP-1. Elixa was the first trial, first CVOT in 2015, but that failed to show significant cardiovascular benefit. But leader trial, where liraglutide was studied, was a turning point because this was the first CVOT to show a reduction in MACEs with GLP-1 receptor antagonists. This was the trial, leader trial investigator with liraglutide, cardiovascular outcomes in diabetic patients. In time to event analysis, the rate of first occurrence of death from cardiovascular causes, non-fatal myocardial infarction and non-fatal stroke among patients with type 2 DM was lower with liraglutide than when compared with placebo. This was Victoza, and now we have an Indian brand, Gliptoza. And this was in 2016. Soon we got another molecule, semaglutide, Ozempic and Wegovy. Here in Sustain 6, again this cardiovascular outcome tried in diabetic patients. Here also the rate of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, everything was significantly coming down. And later this drug was studied in obesity in those patients without diabetes. This was in select trial. Even in those patients without diabetes, just obesity, weekly subcutaneous semaglutide at a dose of 2.5 mg was superior to placebo in reducing cardiovascular events. And now we have an oral form of this semaglutide, that's Ribelsis. Oral semaglutide, again when it was tried in type 2 DM patients, SOLD study. Here again there was a significant lower risk of major adverse cardiovascular events when compared with placebo without an increase in any serious adverse events. So these are the important cardiovascular outcome trials showing significant benefits. Leader with Lira in 16, Sustain, Rewind, Select, SOLD, and you can see these three drugs, liraglutide, semaglutide, dulaglutide, these trials were showing significant benefits to the tune of 13% to 20% of MACE reduction. And this was the largest meta-analysis assessing the same aspect. 13 studies were included, around 83,000 patients were assessed, and in this largest meta-analysis there was significantly reduced MACE, all-cause mortality, CV mortality, stroke, all type of MACEs were less, and the reduced MACE in these patients was shown in those without and with CVD, and those with BMI more than 30 and less than 30, and even in those patients with GFR less than 60 or more than 60. And based on these meta-analysis and cardiovascular outcome trials, European Society of Cardiology, they put forward a guideline in 2023 for the management of cardiovascular disease in patients with diabetes. If you already have a diabetes and atherosclerotic cardiovascular disease which is established, class 1 indication is GLP-1 receptor antagonist or an SGLT2 inhibitor. And you have to start these drugs irrespective of your diabetic status. Even if your diabetes is under control, if there is an established atherosclerotic cardiovascular disease, class 1 indication, start GLP-1 receptor antagonist or SGLT2 inhibitor, independent of the HbA1c level and independent of the other glucose lowering medications there. And if necessary, you can add other medicines like with benefit like metformin and pioglitazone if there is no heart failure. Again in 2024, ESC guidelines for the management of chronic coronary syndrome Again, GLP-1 receptor antagonist with proven cardiovascular benefit was recommended as class 1 indication in those patients with chronic coronary syndrome. And in those patients who are not a diabetic but obese, if the BMI is more than 27, again it's a class 2A indication in guideline, European Society of Cardiology guideline for chronic coronary syndrome. Now, that's with pure GLP-1 receptor agonist. We have, I'm not going to the mechanism of action, we have one dual agonist in the form of tirzepatide. Here, GLP-1 receptor and GIP both will be augmented and multiple mechanisms are put forward, but this is going to be a breakthrough. The effects of tirzepatide, we have cardiovascular outcome trials are still ongoing, but we have some trials like this, heart failure with preserved ejection fraction and obesity. Here, tirzepatide produced comprehensive and meaningful improvement in the outcomes. Again, this was a recent trial in Jan 2025, tirzepatide for heart failure with preserved ejection fraction led to a lower risk of composite death from cardiovascular causes or worsening heart failure than placebo. So, tirzepatide in the form of Monjaro and Zepbound, both were showing benefit. And the story is the same with semaglutide, was tried with heart failure with preserved ejection fraction STEP HFpEF and STEP HFpEF DM randomized control trial. Again, semaglutide also was showing improvement in heart failure related symptoms and physical limitations, and the benefit was superior. And a viewpoint based on these articles on heart failure with preserved ejection fraction, a viewpoint was put forward in JAMA. And here, among these trials, among agents which was tried in heart HFpEF, 3 drugs are showing good benefits. So, they have put forward, we have 3 pillar medical therapy in heart failure with preserved ejection fraction. Even now it has not come into the guidelines, but here we have data with these 3 drugs, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists in the form of finerenone, our next speaker would be talking on that, and GLP-1 receptor agonist, particularly when it is an obesity related heart failure with preserved ejection fraction. But we have to wait for the guidelines, it have not come into the guidelines. So if you compare the key anti-obesity drugs, we have dulaglutide, you can give weekly injections, you have cardiovascular outcome data, but the intensity of weight loss was meager, 3 to 5%, not very popular. But with liraglutide, you have 8 to 10% weight loss, you have outcome trial, but you have to give subcutaneous injection every day. That's one negative point. When you go to semaglutide, you can achieve 15% weight reduction. You have data, cardiovascular outcome data with diabetes, and even in those patients without diabetes and obesity, you can give subcutaneous injection weekly. Good data, significant data, and you have oral drug, even with oral drug, you have superiority data. Now, tirzepatide. Tirzepatide is a dual agonist, but it is very intense. It produces very intense weight loss, around 22% weight loss. But the problem is cardiovascular outcome trials are still not going, surpass CVOT. We have to wait for the results, which will be coming in another 3 to 6 months. It has got other cardiorenal metabolic changes also. It reduces blood pressure to the tune of 4 to 6. Lipid reduction, predominantly in the form of triglyceride reduction. Renal protection reduces the decline of eGFR, albuminuria. Insulin sensitivity, it increases significantly the insulin sensitivity, especially with tirzepatide. It causes fat redistribution, reduces visceral fat and increases hepatic steatosis. So these are the advantages, other cardiorenal metabolic advantages of these agonists. So when you see the evolution of GLP-1 receptor antagonist, it's compared to SGLT2 inhibitor. It started as a drug for diabetes, only for diabetes. But later we found that it's useful in obesity. Now we have even good data that it is useful in obesity and obstructive sleep apnea. It has come in guidelines. And the cardiovascular target here is predominantly atherosclerotic cardiovascular disease and heart failure with preserved ejection fraction. In SGLT2 inhibitor, it was heart failure with reduced ejection fraction and CKD. But here also you have data with CKD. And the obesity impact is very strong with GLP-1 receptor antagonist. And now it's a breakthrough in the business world also. You can see some of the business magazines writing cover stories on these drugs. The weight loss war between Eli Lilly and Novo Nordisk. Liraglutide and semaglutide is a molecule of Novo Nordisk. Eli Lilly has come up with tirzepatide, and now they have come with a triple blockade. And with that triple blockade, the phase 1 and 2 trials are showing up to 25% weight reduction, but we have to wait for the outcome trials to recommend. You can see in 2025, you can see the predominant drug GLP-1 receptor agonist prescribed was semaglutide. Now you can see tirzepatide is surpassing that. By the end of 2030, we are expecting a big market for tirzepatide. Semaglutide market is coming down. It's projected the outcome, that means market would be around $150 billion per year towards the end of 2030. So the take-home message is GLP-1 receptor antagonist is validated obesity as a treatable chronic disease. And this is the first drug to show cardiovascular benefit by treating obesity. You reduce obesity and you reduce cardiovascular outcomes. Liraglutide, dulaglutide and semaglutide have proven cardiovascular benefit even in non-diabetics. Tirzepatide and future agents could redefine obesity treatment and cardiovascular risk reduction further. GLP-1 receptor agonists have evolved to a crucial cardiorenal metabolic therapy. Thank you.